if you don't mind. Thank you so much for joining us, everyone. My name is Carmen Irving. I am the Ohio Council for Family Relations Board President this year. I also work for the Mental Health and Recovery Board as the Systems of Care Director. I'll be just presenting Dr. Phil and handing the computer over in just a second to let him get started. I believe many of you who are joining us today were with us last month when we presented the first part of this series. It was initially intended to be a one-time webinar to really address how opiates are affecting Ohio families. And when we began to put the presentation together, and by we, I mean Dr. Phil, we quickly realized there's just too much to cover in 1 hour. So this is the second part of that. If you're joining us for the first time, please do go back to the Ohio Family and Council Relations website to see that first part of the series. So that's been archived on the web. This is also being recorded and will be housed on our website as well. Later today, we'll be sending you an evaluation for your feedback on today's webinar. We welcome any questions you have. You're welcome to direct those to me, and I'll do my best to get those sent to the correct people. So without further ado, I want to hand it over to Dr. Phil. Dr. Phil Atkins has been in the behavioral health field for nearly 30 years. He's got a lot. Oh, we've got a lot of feedback. So there's some feedback coming, so I just want to remind all of our participants to please mute their microphone. Dr. Phil's been in the field for about 30 years in behavioral health, and it's really his array of experiences that has really made him sort of an expert in our field. So he's worked as a clinician, he's worked as an administrator, he's worked in the field of prevention, and also as a consultant. He's currently our executive director for the Mental Health and Recovery Board of Union County, which is located in Marysville, Ohio. And without further ado, I'll hand it over to Dr. Phil.
All right, we're going to do a very high-tech slide of the computer for me to get on the camera. Welcome to those of you who are joining us for the first time, and welcome back to those of you who have came for the first part of this. As Carmen mentioned, it is archived if you'd like to watch it. We're going to do a little bit of review for our participants here today in terms of what some of the background and setting some context around opiates. We also, as a result of the last webinar, received a few questions, so we're going to throw kind of some random topics in order to answer those questions. And then we will have some time for questions for this webinar. So if you'd like to use the chat box to ask questions or to suggest a topic, I certainly, if I know something about it, I will be glad to address it, or maybe point you to a resource, or certainly follow up with you with your contact information. So very happy to be part of this webinar again today. Just a little bit about the background of this, and for some reason my slides are not going forward. I wanted to give you a little context about who we are in terms of the mental health and recovery boards, or some communities call them alcohol and drug addiction services board, mental health, alcohol, drug addiction services boards. We go by various names in different counties. This is a map of who we are and where we are. We're actually at the state meeting for directors of boards today, and so we're taking a little hiatus during lunch to bring you the webinar. There's some boards are single county, like the one we represent in Union County. Some boards are multi-county, and as you can kind of see on the map. I'll direct you to the Ohio Association of County Behavioral Health Authorities website there. And the map is actually interactive. So if you are a family life educator in one of those areas, you can kind of connect with who your local board would be. I will tell you that in the last budget bill, there was some statutory language change that gave county boards like ours the authority to be the opiate hub for communities. And this is really, I think, could be of potential interest to you as family life educators, because one of the statutory responsibilities of the hub and I'll just read it from the statute here, is to promote family building and workforce development as ways of combating opioid addictions in communities. So every county was funded to have an opiate hub, and will be required to report back to the legislature, and so we want to make it successful. So I encourage you to get in touch with your local board because that family life education and those family strengthening pieces were acknowledged. I think that that's a really a move forward. So use the interactive map at oacpa.org, that Ohio Association of County Behavioral Health Authorities, to get in touch with your folks if you don't know who they are already. We'll be doing Carmen Irving and I will be doing a little bit of a presentation this afternoon for all the state directors, and I will mention to them that I gave them a little plug, and hopefully their folks will be contacting them. So some of the context that we talked a little bit about last time, and this is nothing that we haven't heard, but when you really look at numbers, it becomes very staggering. In Ohio in 1999, we had a population of about 11.3 million folks, and our death rate from drug poisonings, unintentional overdoses, was about 4.2 per 100,000. And that was, all of the unintentional overdoses that could be overdoses that were unintentional, as in, someone just actually took too much medication and there was some complication, or an actual overdose from opiates. By 2014, we had gone almost 5 times that to a death rate of 24.6 per 100,000. So that's a huge trajectory, and we all know, we've seen it. Many of us have experienced it in our own professional careers and in our own families, unfortunately, that we know that this has been a spike. Unfortunately, Ohio is kind of the ground zero for opiate death by unintentional opiate overdose, and has really, unfortunately, led the nation in the epidemic. This is the age-adjusted unintentional overdose death rate per 100,000 by county. You can kind of see there are areas of the state that are very hard hit. Southwestern Ohio, Southeastern Ohio, certainly among the highest. We have, Montgomery County, currently as of 2016, was our highest in the state with 42.5 deaths per 100,000 of population. We did have some counties not reporting or that their calculated death rates were fewer than 10 individuals. So they excluded those from that data. So you can see it has, happened across the state. Your community has been affected just like every other community in Ohio, unfortunately. This was one that I shared last time that I thought was really an interesting piece, and maybe a little known resource for you for family life educators. In fact, I just gave Carmen an entire copy. I downloaded the PDF and printed it for an early birthday present. So I spare no expense. I copied in color the whole bit. So 206 pages. But the Public Children's Services Association of Ohio has on their website a fact book that they publish, I think, every 2 to 3 years, that kind of looks at trends in the child welfare system, what's happening to families in local communities. And the address of their fact book is on the screen there. But here are the child removals due to opiates, the percentage of child removals that are due to opiates in different counties. So you can see that there are some counties that, the vast majority of places are opiate related. So it's certainly hit every system that touches a family and a community across the board. But definitely check out the PCSAO fact book. There are county profiles. You can click, it's interactive. You can click by county and get the information for the county or counties that you represent. Some great background source material for grant writing and just for your own program planning. About a year ago, the New York Times ran an article about a family, and they published their names. I didn't put the last name in here, but they included an article about a family where the father had 3 children and had a large family farm down in southwestern Ohio. And the 2 of the children have unfortunately died from an unintentional overdose on heroin. His son that he's pictured here is in kind of fragile recovery. And it's a thing that a lot of our rural families are facing. We've done quite a bit of work with our local farm bureau and, with Extension to talk about the impact, particularly on our rural families, because, excuse me, the opiates, while we often think of urban centers as being the kind of the location of all of those social concerns, our rural families have been really impacted. But it was a great article. So if you want to Google like the New York Times Opiate Ohio article, it describes this father's dilemma of, do I leave this land to my son who is in fragile recovery? And so it has really interrupted a lot of family transition and things that we don't necessarily think of when we think of just the overdose piece. But great article. So kind of switching gears a little bit to some of the kind of the behavioral and treatment concerns. One of the things that we look at when we are diagnosing substance use disorder, and that's what we call it now. It used to be chemical dependency. It used to be called a lot of other things, but it's called substance use disorder now, are the 3 C's: control, compulsion, and chronicity. And in very early on, we see that loss of emotional and behavioral control around their ability to use. And so tolerance and withdrawal are key hallmarks of how we would diagnose kind of symptomatically opiate dependence or a substance use disorder. But definitely that compulsion to continue using despite adverse consequences, and then also the chronicity, the chronic nature of multiple relapses and the kind of the ongoing issues around recovery. This is really important because it flies in the face of what a lot of the general public believes about the opiate epidemic. And it certainly impacts what they ask for when they ask systems like ours for treatment services. We hear a lot about the need for detox beds, and detox and withdrawal management is kind of what we call that now. So we hear a lot about withdrawal management and the need for detox beds. And while that's important that people can kind of comfortably withdraw from opiates, typically withdrawal from opiates is not life-threatening. And so, many people withdraw from opiates on their own. Unfortunately, a lot of them may withdraw in a correctional setting, a jail or prison. But the chronic nature of this, and withdrawal and detox management and detox and all of that, that's an acute event that happens acutely. And many people think, okay, kind of once people are withdrawn that, they're well on their way. What we know, though, however, that this is really a chronic concern, and that at 4 years out, there's still a 25% chance of relapse. So folks who have gone through detox, who have gone through recovery, who are working with good social supports and have had treatment, at 4 years, they still have a very high risk of relapse. So we have to look at this a little bit differently. And one of the ways that we're doing that is through medication-assisted treatment. And there are 3 medications that are approved, FDA approved, to be used in the treatment of opiate dependence. And they are methadone, buprenorphine, and naltrexone. Methadone, we kind of have had around for a long time. It's been around since the 60s. People take it daily. It is something where you have to go to a specially certified opiate treatment program. Many, many communities, mine included, does not have a methadone clinic. They tend to be clustered in urban centers. There are a lot in Southwest Ohio in the Cincinnati area. There are a lot in Franklin County and Lucas County and Cuyahoga County. But the rural folks tend to either have to drive for methadone maintenance, or that is unavailable to them. And the difference in these three medications are the way that they interact with the brain chemistry, or what we call the mechanism of action. Methadone is a full agonist, meaning that it is just like other opiates. It binds with the mu receptors in the brain just like other opiates do. So your brain doesn't see a lot of difference and discern a lot of difference in methadone. And so that's why it's so tightly regulated. Methadone, as we know, is used to treat other conditions, some chronic cancers and some chronic pain, and certainly, has been around a long time. So it's known as a full agonist, meaning that it binds to the brain cells and brain receptors just like another opiate. Buprenorphine, which is Suboxone, is a partial agonist, meaning that it binds to those mu receptors in the brain partially, so it kind of covers them and allows the brain to not experience as much withdrawal. And it's usually done as a sublingual film, something that is placed under the tongue. So that format was created to help with diversion because folks will use that to stave off withdrawal. Or now it's available as an implant under the skin, similar to like long-term release medications. Some birth control methods are used as an implant. Naltrexone is a total agonist, meaning that it completely blocks reception of those mu receptors around opiates. So it helps immediately with craving. That there are oral formulations of it called Revia, which folks often take at initiation of this treatment. And then there's also an injectable form called Vivitrol. So, and the availability of these drugs is pretty common in communities, with the exception of methadone. For buprenorphine or Suboxone, folks, prescribers have to have a special waiver through the DEA to provide, and they're only allowed to provide up to a certain number of cases. Clients, or manage a certain number of clients at a time, and it has to be a physician. With naltrexone or Vivitrol, any prescriber, including advanced practice nurses, can prescribe that. And the advantage with the naltrexone or Vivitrol is that it's a monthly injection, and so it helps with compliance. Folks don't have to take a daily medication. All of these medications are covered by Medicaid, and most of the folks that we see in our community that have opiate dependence have Medicaid. Very few have other commercial insurance, or we as a mental health and recovery board cover the cost of these medications for folks who aren't on Medicaid. So it's expensive. Naltrexone's about $900 a shot. $900 a month, but certainly when we consider the life impacts, it's a bargain compared to the treatment and also to the cost of human life. So. There are some myths about medications, however, and I hear these very frequently, and we've even had to overcome them in our own treatment systems and own treatment providers. And methadone and buprenorphine or Suboxone do not kind of substitute one addiction for the other. People very often will say things kind of make blanket statements around the fact that, hey, they're just substituting one thing for another. It really is, it has become malpractice not to use these medications. Even the most abstinence-based treatment centers are now starting to realize that this type of addiction and these types of situations require a different approach. So it is best practice to use medications, and it's not just substituting one thing for another. Folks who are using buprenorphine and even methadone can live very productive lives, and there isn't the involvement in crime, there isn't some of the other social concerns that come along with that. The other thing that people often believe is that the diversion, particularly of Suboxone, is common. And while there is some diversion of Suboxone, it is typically used to stave off withdrawal. And what folks will do is, if they have a Suboxone prescription, or if they can get Suboxone on the street, they will use that to avoid going into withdrawal when another opiate, heroin or some other opiate, illicit opiate, is not available to them. But it is less common than kind of sometimes that myth would suggest. The problem with medication-assisted treatment is that we definitely need more of it. You can see that there are very few U.S. physicians are actually licensed to provide medication-assisted treatment, and even fewer of those who have the certification and DEA waiver that they need to prescribe, particularly Suboxone or methadone, actively do it. So, 11,000 docs in the country is certainly not enough to meet the demand for medication-assisted treatment. We started to talk a little bit in the last webinar about stages of change, and the trans-theoretical model of change is one that we apply to a lot of behavioral change, and certainly one that applies well to opiate treatment and recovery. Very often folks who have an opiate use disorder are kind of unaware that they need to make the changes, or if they are aware, they're only kind of vaguely aware that this has become problematic for them. It doesn't really come to your consciousness. I liken it to my constant struggle with the size of my pants, because you constantly struggle with weight, and there are days that it doesn't even hit on my radar that this is something that I need to change behaviorally. And then there are days that it kind of pops up, and usually when I can't get things buttoned quite as easily. So then we have contemplation, where people are kind of aware of a problem and are seriously considering a change, but no commitment to action is taken. And so we have to really find these places that we can intercept folks in their stage of change process. So that contemplation piece very often happens when at unintentional overdose. And we know that that's happening in communities. We have great access to naloxone, which blocks the effects of opiates. It's a total agonist that first responders, emergency departments, and now even some family members are keeping on hand. It is available now in Ohio without a prescription, and so there are commercial pharmacies that carry it. And usually through your local health departments, you can get training in how to use naloxone to provide aid to someone who is in the throes of an unintentional overdose. So there are a number of good programs out there, but that's really an intercept that we need to work more consistently at, because we hear from our first responders that they have been to a certain house in our community, or they've seen certain folks, they have used naloxone, they've used Narcan on them to revive them, to bring them out of opiate overdose, and then the folks refuse to be transported for any kind of treatment, or refuse any kind of treatment information. So that's an area. Quick response team, a QRT or rapid response team that pairs folks with their local law enforcement, local first responders, and also treatment agencies that kind of respond to the scene fairly quickly. And then obviously the preparation, and where people will make small behavioral changes. With opiates, the preparation phase doesn't really, it's not protracted, it's very short, because people, it's not like you can just start to use less or it's not like cutting back on dessert. So the preparation phase tends to be a little bit truncated, and then the action phase, when folks really decide to take decisive change. And this is kind of escaped us as the response system to opiate is, the typical things that we think of that might motivate you or might motivate me to take action toward behavioral change, because the physiological compulsion is so strong around opiates, may not have folks take action. For many of us, if the thought of losing a child, having our children taken away, or losing a job, or doing all those are things that would motivate us to action. What we don't understand, and most of us have not experienced, is that physiological compulsion that happens when someone has an opiate dependence. So, the things that we think would typically be leverage are difficult, and it's difficult for us to sometimes engage folks because it's not the typical suspects of what might move somebody to action. Very often, folks who are moved to action are done so. They are moved through the criminal justice system, and we have a number of specialized dockets around the state. Drug courts are very effective. They are used to hold charges kind of in advance. And then folks can be involved in a specialized docket of drug court. They go before the judge typically every week, and they're monitored very closely for a period of about a year to 18 months. And that's where we're really seeing the effectiveness in our treatment for folks with opiate use disorders. Unfortunately, that has created a dual track for opiate users, and that there are resources available to folks who are involved in the criminal justice system that are not available to folks who are opiate dependent but not involved in the criminal justice system. And that's something that we systemically really have to address. And then finally, when we talk about maintenance, that working to prevent relapse and to provide consistent support. We do that through recognizing that relapse can happen at any point along the continuum of the stages of change. So, this is not a linear process. It's a very circular process where even folks who have, maintained sobriety for longer periods of time are still at risk. Like I said earlier, that 4-year statistic, still a fourth of folks tend to relapse. We talked a little bit about the definition of the acute care model, and we have typically seen substance use as kind of an acute care model. We'll come in, we'll detox folks, we'll maybe give them brief treatment, 28 days, 90 days, whatever typically is available, and then we'll move them out. What we know now is we have to move to a much more chronic care model, and really focus on the process of change that is recovery. I think we shared this last time. The recovery definition is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Because the opiate epidemic has become so pervasive, and we see so many of our young people, particularly that transitional youth age, that 18 to 25-year-old, this is really difficult because we're not talking about rehabilitation with many of these folks. We're talking about a habilitation environment where we have to teach those skills from the ground up. Traditionally in addiction services, we've talked about rehabilitation, where someone has focused at a level or functioned at a level, they've progressively, their addiction has progressively taken them to a lower functioning level, and then we need to get them back up to their functioning level. But what we know is that for many of these younger opiate dependent folks, their functioning level has been here, and so we're actually having to teach skills from scratch, which is much harder. I liken it to the difference between building a road and driving a road. When you build a road, it takes a lot more effort. You have to clear all the trees, you have to do all the work, and then driving the road becomes much easier. So we're really building roads for a lot of these folks. We are moving to a recovery management philosophy, and I don't know how I'm doing on time here. My timekeepers. But we are looking at recovery management and all of those domains that folks need to improve their quality of life. And communities can have varying levels of recovery capital. Individuals can have various levels of recovery capital, which are those internal and external assets that help people sustain recovery. And as communities are coming together to deal with the opiate issue, it's very important that we look kind of systemically at what's the recovery level of recovery capital in our community, to say, okay, we have good access to treatment, we have good access to doctors, we have good access to recovery supports through 12-step communities, we have our faith communities are accepting and embracing and train or at least informed to help folks recover, our employers, our businesses. So we need to make sure that the recovery capital and the assets that we can help use to scaffold around someone's early recovery are available in our community. I think we talked a little bit last time about recovery-oriented systems of care. And this is a nod to our more chronic care model. We know that treatment and rehabilitation are one piece of a recovery-oriented system of care, but what we also know is that there are many paths to recovery. There are people who are in recovery from lots of different kinds of things, from mental health concerns, from opiate dependence, from alcohol dependence, that never really got treatment or rehab. They found maybe social support, or it was a primary relationship, or a job, or a faith community that was supportive. So we have to acknowledge that while there is a lot of science around what folks need to recover, that recovery is an individual journey and that there are many paths to recovery. And treatment and rehab is just kind of one path. And, the conventional wisdom was, somebody came in, they were diagnosed with a substance use disorder. They went to 90 12-step meetings in 90 days, and, they were well on their way. And that's just not the way it is anymore. Certainly 12-step programs are vital to many people's recovery, but it's just a kind of a different environment. Some of the underlying values of a recovery-oriented systems of care is that it's person-centered and self-directed. It is strengths-based, and in many cases, the recovery planning for folks have the involvement of family members, other significant folks, wisdom figures to that person, and it helps to bring folks back into the fold. So we've talked a little bit about the many paths to recovery, and we are trying to make sure that we leave no stone unturned in terms of our ability to intervene and build recovery capital for folks. Certainly non-traditional methods. Peer support has gotten a huge boost, and in our meeting this morning with all of the state directors, we're hearing that even the Medicaid managed care organizations are very interested in peer support. And peer support is kind of a new phenomenon. And we've always had AA, we've always had sponsors and case managers, but certified peer supporters are folks with lived experience who have kind of been there, done that, who go through specialized training, 40 hours of online training and 40 hours of classroom instruction to get certified as a peer supporter. So there is an actual certification exam that they take, and then they help people. They kind of stand in the gap between a sponsor and a case manager, And we're looking at how we can creatively use certified peer supporters to really help folks. For example, in our community, we have certified peer supporters that run recovery groups. We have certified peer supporters that meet one-on-one with folks who have particularly opiate use disorder. And so that whole idea that people with lived experience are now sort of professionalized. We've always had the sponsor tradition in the 12-step programs, but now we have kind of kicked up a notch the role of certified peer support because the outcomes are good, and we know that there is a certain kind of validity to someone who has kind of been there, done that. And so many communities have consumer-operated services where they provide certified peer support. I know that in practically every community, there is either peer support or interest in peer support. I hear it among my colleagues all the time. It's something that we're certainly interested in funding and making available. There are some challenges with peer support, and we're still trying to kind of find our way a little bit with peer delivered services. Some professionals have difficulty with peer services. I've been around long enough that I remember when case management came in, and the therapists were all up in arms that case managers, here's somebody who's actually going to be going to somebody's house and helping somebody learn how to shop for groceries and do all of the things that case managers do. That has actually worked out well, and it's now kind of an accepted part of the treatment team. Peer support, I think, is becoming more accepted. We definitely have to make sure that we maintain some level of professionalism. There very often dual relationships become an issue. Because those folks are in recovery, the same kind of recovery groups as their peer supporters. So that's one of the things that the training really stresses, and also supervision around ethical boundaries. And it's just kind of an emerging discipline. And I think we've got some growing pains, but it's really, really helpful. This is something that I really wanted to throw in because it's another one of those kind of big myth areas. And we get calls in our office every single day from somebody who has a son or a daughter or a niece or nephew, or sometimes the person who has the dependents themselves calling and saying, hey, I need inpatient treatment. And I need to go away and get out of the community and get, go to a hospital for a long time. Back when I started in chemical dependency counseling, which was in the late 80s, insurance, if somebody said that they needed inpatient treatment, insurance paid for it. And lo and behold, there were 40-day treatment programs that popped up. And there wasn't any magic about 40 days. It was what insurance paid for. And then it came the 28-day stay. So programs developed 28-day programs. And again, there wasn't any magic around the 28 days. It was what insurance would pay for. But the addiction science has really developed in the last 20 years. And we use treatment protocols very much like you would use a treatment protocol for any medical condition. The American Society of Addiction Medicine requires us to assess folks in 6 domains or 6 dimensions. The first dimension is their acute intoxication or withdrawal potential, so that they have, so that we know, is there an immediate need that, or an immediate concern, life-threatening concern around withdrawal as the person, actually intoxicated. So we score folks in this dimension. The second area would be any biomedical complications or conditions. So if somebody has diabetes and they're in alcohol withdrawal, obviously that's a comorbid condition that we would need to address. If somebody has other physical conditions that might complicate recovery. So their health history becomes very important. Dimension 3 are their emotional, behavioral, or cognitive conditions. We want to make sure that we are addressing any comorbid mental health concerns, the presence of depression or anxiety or bipolar disorder or thought disorders, and also just kind of the general emotional state of the client when they come in. Dimension 4 is very important because it's an individual's readiness to change, and I really like that that's part of our clinical assessment. And very often we get family members calling us who are very ready. They are very ready to have their loved one change. And I always make them put that person on the phone, and if that person won't even come to the phone, then obviously that readiness to change dimension is not, we aren't quite there yet. Dimension 5 is relapse and continued use or continued problem potential. We give a little bit of a prognosis about what might be the relapse potential for this particular consumer. Often that's based on history. The best predictor of future behavior is past behavior. So we look at how has this person been triggered to relapse? What is this their first treatment episode or the 15th? And then finally, their recovery and living environment. Again, we want to make sure that recovery capital, that we have a good sense of that when we are treatment planning. So after the assessment in these dimensions, and agencies and treatment providers use different tools to assess these dimensions, but kind of at their core, we use multidimensional assessment across the board. Then we have patient placement criteria. And patient placement criteria reflects a kind of a continuum of care, everything from 0, which is no treatment indicated, to a 0.5 level of care, which might be early intervention, through outpatient services, intensive outpatient, residential, and then medically managed intensive inpatient services. So obviously folks who have higher acute withdrawal potential and other kind of comorbid physical things are probably going to get moved up the list and in intensity of care. So people are very often frustrated, and they don't understand that, that there are placement criteria that we have to follow, and everybody kind of wants to immediately go to the Betty Ford Center, which would be great if we could send everybody there and have what they kind of believe is a treatment experience. Not infrequently, I will ask folks who call, have these folks ever, has there ever been any treatment? And folks will say, no, they've never had treatment, they've never had anything. And then I find out that, well, they've been in outpatient treatment, but because of, kind of the prevailing wisdom and belief system around treatment, they've said no, because they think that that inpatient treatment is the only level of treatment. Most folks are usually in the intensive outpatient treatment area when we talk about opiate dependence, so a level 2.1. So intensive outpatient is the standard is that folks go at least a minimum of 8 hours a week on 3 different days a week. So they will attend group, they'll attend individual, and then they're typically expected to do some other recovery activities. So they get a lot of psychoeducation at that point, a lot of group therapy, and intensive outpatient is pretty much the gold standard, along with the medication-assisted treatment that we combine for most folks. Very few folks really need that medically monitored intensive inpatient service, or particularly they don't need it after withdrawal management. So after they've detoxed, they tend not to need those services. So just a little bit, because we get frustrated, people that call us all the time, or why can't these people get treatment, and why is there no treatment in our community? And when in fact there's a lot of treatment, it's just not what people believe treatment to be. We had some questions, and I'm going to transition now a little bit to kind of my favorite end of the continuum. There's the analogy of the fish dying at the base of the river. and the opiate epidemic has been a massive, you know, massive event where at the base of a river, fish are dying all over, and we've done amazing things. We've revived some of the fish. We have mourned other fish. We've honored the lives of some of the fish, but we have not always said, okay, let's go upriver and see what's making the fish sick in the first place. And being a preventionist, an Ohio certified prevention person, I really, I believe that we cannot treat our way out of the opiate epidemic or any social concern, that we have to provide prevention, and that's where we engage a lot of things like family life educators. And so recently, in the last, some federal legislation happened that the PACS, that was called the 21st Century Cures Act, and the 21st Century Cures Act provided federal money for states to develop strategies around the opiate issue. And while a lot of treatment strategies were developed and treatment capacity was enhanced, in that legislation was a special earmark for some of the dollars around prevention services. So in Ohio, in kind of an unprecedented move in Ohio, the state of Ohio is promoting two evidence-based strategies. One is the PACS Good Behavior Game that we'll talk about a little bit in terms of that I think you would have some interest in, and then the Botman life skills area for older kids, middle school age. So the PACS Good Behavior Game is a set of research-based strategies that are employed through classrooms to teach self-regulation. So what we know is that kids that can manage their own behavior, who know when to put on the brake, when to put on the gas, and can do that effectively and consistently, have dramatically better outcomes. And so the PACS Good Behavior Game is based on things that little units of behavioral intervention that are evidence-based to make an impact on self-regulation. And they call these little units of behavioral intervention kernels. And so the best explanation of a kernel that I think is from one of the primary authors of much of the literature around kernels, Dr. Dennis Embry, he likened them to bread. Kernels, you know, bread is flour and water. If you have flour and water, you can make bread. You can certainly add all kinds of things, but you can add raisins and yeast and cinnamon and all kinds of things to bread to make it, you know, more interesting. But at its core, bread is flour and water. The same is true, and if you take away one of those things, you no longer have bread. So what this particular set of scientific kind of studies did was take what were the irreducible, what was the minimum thing that is evidence-based, little intervention that's evidence-based to show behavioral change. And they put them together in a really creative way and layered them on top of each other to make an approach that really builds self-regulation in kids. This is a little bit of what happens to kids when they have when they're exposed to some of these behavioral kernels. The PACS Good Behavior Game has been funded, and of the 75,000 kids that elementary students that they're expecting some really dramatic outcomes. So if all of those 75,000 kids in Ohio get PACS, we'll see about 6,500 fewer people will need any form of special education services. And particular to the opiate epidemic, about 7,200 fewer of them will develop serious drug addictions. I'll give you the web address for where you can find some of this data. So with the 21st Century Cures dollars, The state of Ohio is training 1,000 additional teachers in the PACS Good Behavior game to use it in their classrooms. There's also a companion version of PACS and those kernels called Kernels for Life that we are doing in the community, and we certainly can give you some more information on that. I think that would be a great webinar for you who are interested in knowing more about the Kernels for Life program. But these little interventions are scientifically shown to increase self-regulation, and when we increase self-regulation in kids, we have dramatically improved lives. Both PACS and kernels are built on the Creating Nurturing Environments framework. This is some work done out of Oregon from Dr. Anthony Biglin, and there's a lot of good journal articles for those of you who are geeks like I am, or there's a great book called The Nurture Effect, and in that research, he identifies 4 key elements or 4 key domains of a nurturing environment. Richly reinforcing pro-social behaviors, reducing toxic influence, limiting problematic behaviors, and increasing psychological flexibility. And when we put scientific intervention of kernels in one or more of those domains, and we richly reinforce kids and their behaviors, or we reduce toxic influences that may traumatize kids, and we give them good limits on their problematic behaviors, and we help them be more psychologically flexible, amazing things happen. And certainly that is absolutely true in my experience of implementing the PACS Good Behavior game and Kernels for Life. So I really encourage you to check out if there are still trainings available around the state. So if you go to paxohio.com, .org, paxohio.org, paxohio.org, you can find out more about the PACS Good Behavior game and some of the trainings that are available. They're at no cost to folks. If you work closely with the school district, I really strongly encourage you to work with them to bring PACS to your community. So it's an amazing set of interventions that even in good schools have made a huge difference. So I will let you know that your illustrious chairperson, president of the Ohio Council of Family Relations, is a prime Kernels for Life trainer. So she can send you information. Carmen Irving can send you information about that. So we'll have her contact information available for you. So at this time, do we have questions? All right, so do we have any questions? We'll give them just a second while I take a drink of water.
So Dr. Phil, this is Patrice, and at the moment we have participants on mute. We do have a group chat. I'm not seeing any questions come up in the chat at the moment.
Okay. I know we did have some questions on what folks can do on the prevention side. Certainly that PACS Good Behavior game and Kernels for Life. You can go to the paxohio.org website, or you can go to our website, mhrbuc.org, Mental Health and Recovery Board of Union-County.org, mhrbuc.org, and look up some PACS and kernels information, and there's some really good stuff. Probably I will just share with folks that when I was starting into my PhD program, I was really looking at leaving the behavioral health field altogether. I was going to go back into general kind of healthcare environments, and part of the reason I was leaving is because of the hopelessness of the opiate epidemic. Certainly, we know that folks have a lot of us have experienced and are experiencing compassion fatigue and vicarious trauma that is just really making us question why we do what we do. And part of that was, because it was so hopeless. Then when I saw PACS and when I saw the kernels in action, kind of wearing my prevention hat, I thought this is really a set of universal strategies that can make a real difference. And so it really reinvigorated me. So we do have one question. Three questions, actually. Okay.
Webinar. I thought it was at June or at 1, and it must have been at June.
That's a great question about nutrition education and combating the opiate epidemic. One of the things that we know is that folks who have opiate dependence neglect a lot of their primary physiological needs. We see folks in dental care.
She's answering questions from the studio audience. That second part of that, the effects of the opiate epidemic on Ohio families.
Let me try and see about, hang on one moment, please.
No, I missed it.
We're waiting for a question here.
Okay, I think we got rid of that feedback. Carmen, can you see the chat box?
We cannot.
No.
Okay, so I did see, we just had a question about the website for PAX, so we got that in, paxohio.org.
Great.
And then I think Carmen had gotten the others emailed to her.
Go ahead.
Right. So we have a couple of things. What is the role of nutrition education? And I started to say that folks who have opiate dependence very often neglect all physiological aspects. When we talk about building a holistic recovery program, I think folks really do need that nutrition education. We know that a lot of folks who have opiate dependence are folks who are living with very limited resources. We actually utilize nutrition education in our sober living, our recovery residences, and help people kind of either stretch their food dollars and their resources, and if they're getting some sort of food assistance, supplementary nutrition assistance, we try to work with them on that. I think that's a really great one. And so I would suggest if somebody who has a unique skill set or role in nutrition education might look at contacting some of their recovery residences in their community. You could probably find out where they are through your local mental health and recovery board. So you could say, might those folks need some, nutrition education, because it's a collective living environment that I think, would be very, very beneficial. I know that one of the things that we've done with our recovery residents, and by we, I mean Carmen, has done in collaboration with our local health department, is put community gardens in our recovery houses. So folks in our recovery houses and also at our consumer operated service can learn to grow and process and prepare foods that are healthy. They have a community garden, and it builds kind of that whole around the whole science of the collective with that. So the community gardens at recovery houses has been a really big hit. The second question was, is there a crisis hotline for someone wanting help with opiate addiction? Most communities, in fact, I think probably if you would look through your that interactive map from the Ohio Association of County Behavioral Health Authorities that I showed in the beginning, has a crisis hotline. Some are regional, some are local to that community. So we operate a 24-hour hotline. Most communities do have them for mental health and addiction needs. So check out that map. And there's at this point, there's not a statewide one that is like kind of that funnels in back into the local communities, but there certainly is, there are available in most communities. The last one is, what research is most needed in this area? I think it would be really great to have some research around what really motivates folks to action. And again, for most of us, an adverse experience like having a child removed, or not being able to get a job, or even an unintentional overdose, being revived with Narcan, that would be a motivating thing. But I think research around motivation to action would be really great. I also think that we are going to need a body of research, particularly around the neglected population of the kids of these addicted folks. You know, we do not have a lot of truly evidence-based programming that are either self-contained curricula or even curriculum standards around how we deal with the kids of these opiate addicted families. We know that, you know, more kids are in the child welfare system because of opiates, but, you know, we don't have anything specifically for kind of that level 2 or tier 2 intervention, or that more indicated group, selective group of kids that might be at risk because of their experiences. And I would love to see some really good research and development around that, because we all need it. We have these kids in our communities, and if we're going to keep them from being at risk, obviously there are things that we can do kind of in a universal way. But what happens when these kids, are not just part of a universal audience, but they are kids that have actually experienced some of these kind of relational traumas? So I think that takes us to about 1 o'clock. And again, I thank you for tuning in. I hope it's been helpful and interesting. We're happy to answer any follow-up questions you might have. You are welcome to email Carmen, and it's carmen@mhrbuc.org. And she'll get me the questions, or we can answer the questions. And thank you for being on the front lines of family life education. I think it's one of the most important things and investments we can make, and really a long-term strategy around opiates.
Another graceful shift of the computer. A big thanks to Dr. Phil for spending his lunch hour with us. We're going to let him go so he can get a quick bite before going to his next presentation. So again, thank you so much, Dr. Phil, for your time. Thank you so much for our audience for tuning in. I look forward to any questions you may have. We'll be sending an evaluation as well as another invitation for a webinar we're hosting on Monday from 11 to noon, really looking at how you move along in that process from provisional to full certification for Certified Family Life Educator. Thanks so much, and have a great day. Hope it's not raining where you are. Take care. Bye.